Hello.
Hello, how are you?
Yeah, I'm fine. How are you?
Yeah, thank you.
So the internet connection, I think it works.
Yeah, it works very well.
Okay. The only thing is that I cannot see the participants. Let me try. Okay, before beginning, how it is in Ankara?
The weather, or
No, the
did you ask weather?
condition, the no,
Huh. COVID
the
condition
COVID,
is
yeah.
not good, not bad, because after the normalization period, the numbers of the affected persons started to increase. Unfortunately, nearly in 4th of June, our government decided to change everything as happened in the past, and the normal life after the normal life starts, the problems starts, but it's under control. Several institutes are working on the COVID therapy, and we are also making some scientific studies on it. And the clinical situation is not so bad in Turkey, because our Ministry of Health organized a very good system for follow-up, and it worked very well. But most probably it is related to the genetic conditions, so like HLA variants, like HLA-35. It caused some protection from the high-risk infection, and it seems like good. Helps us to take it under control.
Most probably, yes.
Yeah. And what about the current situation in Iran?
Actually, I can say the same. We had a research of the number of patients, but the new cases, it seems that they are very mild, and severe cases are not increased based on the news. And it seems it's tapering, the signs and symptoms and severity is tapering, and I think everything is going to be better and better. I hope. Hopefully.
Yeah, I also hope that, like that, because if the vaccine problem is solved, it's going to be better for all of the populations, because I really don't know otherwise what we will do, because it's most probably lasts nearly for 5 years.
Professor Ceylander, or Ceylaner.
Ceylaner,
right?
yeah. Ceylaner, yeah.
Or may I call you Dr. Serdar?
Yeah, please.
Yeah, okay. Actually, we have organized this live Instagram and video to have a discussion about the familial cancers, like as breast cancers or any cancer, depending on the genetic mutations or segregating in families. And so our audiences are from different populations, I think physicians and medical students and genetic students. And if you let me, we will go directly to the discussion, as the time of Instagram live is not very long. So I begin with the main question. First, I want to introduce you to our audiences. So Professor Serdar is a medical geneticist with an MD background, and you are a associate professor in medical genetics and the founder and owner of Intergen, if I pronounce well, genetic center in in Ankara, and I'm very happy to have you in our Instagram live. So, I dive into the questions without further ado. And the first question is that, what's your opinion about the genetic test in families with or without background of cancers? Is it important, and what do you think in your experience? Is it really important to do genetic tests in the families with or without cancers?
Yeah, I'm a clinical geneticist mainly, and I'm working in a laboratory, and mostly I'm making the translation of genetic results to the clinic, and I'm examining and following patients. That's why I want to express something about the clinical effects of genetic testing. Because in the past, yes, we detected something in the family. If we could not do anything about the therapeutic point of view, but now we started to make several things. That's why we are now offering genetic tests much more frequently. Nearly 10% of all cancers are familial cancers, but this is the knowledge of this time. And in recent years, some polygenic types of familial cancers are started to describe. And especially in recent 2 years, the polygenic risk scores for cancer genetics is started to describe. In this in this group, there are more frequent type of familial cancers are present. And in this group, for example, we are, as we know, the familial cancer is very frequent in families who has early onset cancers and atypical cancers, rare type of cancers, and positive family history. But in some cases, with the polygenic risk scores, we are evaluating some families whose cancer starts later age, like 50, 60, or a little bit more later. And in those cases, when we are making some genetic tests, we can sometimes detect some multifactorial reasons. And in those families, the other family members has increased cancer risk. The most important thing, one of the most important things is to save other family members. But the other important thing is deciding the therapeutic protocols. In some familial cancers, now, for example, cases with BRCA mutations has new therapeutic options now. And that's why we are offering some genetic panels, or in some families, if they have an exact clinical picture, we are offering some genetic tests, simple genetic tests to detect the exact cause of the familial cancer. But on the other hand, in some cancers, yes, there is no familial background, but genetic tests sometimes present their other genetic disorders, which may cause some complications. For example, if the family has a mutation, or the patient himself has a mutation causing a renal problem or liver problem, this is very important during the therapeutic protocol selection. And the other important thing is the detection of the other pharmacogenetic issues. If the person has some metabolic problems about the drug metabolism, it has an effect on the therapeutic protocols. The genetic is everywhere of the cancer therapy, and it is not from the only one site. But we have to, all the oncologists must work with several types of geneticists, like laboratory geneticist, cancer geneticist, clinical geneticist. We have to work for those patients as a team.
Yeah, referring to what you said about the actually seeing the patient as a whole, I mean, seeing all the different genetic characteristics in a patient, because it will interfere with the therapy as well. I remember I had a case with breast cancer, and but the symptoms were very vast. And in doing whole exome sequencing and watching to other mutations, they found two other pathogenic mutations, one in cystic fibrosis, which complicated the signs of the cancer.
Yeah, yeah.
So I think you have the same experience and many patients with the let's say complicated landscape of genetic results. But do you think we need to have a pharmacogenetic analysis on the genome at the same time that we analyze the patient, or we need to just see how therapy goes on and if there is any problem to do pharmacogenetics? Because I think there is some ethical issues maybe.
Yeah, you're all right. In the past, when the genetic tests were so expensive and so difficult, we were planning like that. If if we will see a problem in the patient, we made some genetic tests. But now, I think in 1 or 2 years, we will have to decide make genetic tests more frequently especially for the pharmacogenetic tests, because we know that most of the cancer therapeutics cause some clinical problems also, and it is very frequent, and in those cases we will have to detect this problem before we will start the therapeutic protocol. But now we are waiting for the problem first, and then we are starting the diagnostic studies. But it is not a favorable way to make such a clinical application, because it's very frequent. Near 5 to 10% of all cases has some clinical problems due to the therapy itself. And United States published a study about cancer, and they said that we are causing the death of nearly 20% of all patients due to the cancer therapeutics, not the cancer itself. Yeah, it's a very big problem. That's why I think that especially for the specific types of the drugs, we have to offer pharmacogenetic testing before the therapeutic protocol.
Yeah, I saw the paper, and I also remember another paper that, nowadays it is changing, everything is changing, even in the genetic test. And for example, in breast cancer, we are different levels of screening, which begins with the clinical screening, and after that selecting families for genetic analysis. And there has been a recent article that shows that we miss at least 50% of mutations in the population using clinical screening. And as the price of whole exome sequencing is reducing dramatically, I think you're right, and we can go to the next level and think about having a kind of screening very early. But as you know, there are some discussions. I myself began my medical genetics in old school. Then we could have only analysis of one gene, and it took at least 6 to 8 months to analyze BRCA1, BRCA2. We had many patients in France. But nowadays, it's becoming very handy and at hand to do the whole genome analysis and to have all the information. Are you favorable for the genetic tests that are called health genetic tests very early in the life, which sees and look at the different mutations, maybe polygenic factors in health, in predicting cancer or predicting different polygenic disorders, like as the risk of, for example, diabetes, the risk of Alzheimer's disease, or schizophrenia, or different things. Are you favorable for this kind of test, or you think we need to stay a little bit?
We have to wait for a little bit because some data is not so clear in the literature, and some of we know some of the variants causing some high risks, but screening is not a favorable thing, I think, now, especially nowadays. But in 2 or 3 years, most probably after we will collect more data about these issues, we can start it maybe. But now it's so, because it may cause some pressures on the family or the patient, and it may cause some psychiatric problems and a pressure on the family. And I think it is not so necessary. Yes, genetic is developing, but it is not very well developed now. And as you know, there are several companies originated from United States, and they are making such a test. And I think it is now a trait. It is not has strong scientific background. But if the family has a strong background, positive family history, yes, we can do something. But I thought it is not a single prescription. We have to evaluate the family first. We have to get some detailed information, get a good anamnesis, and then we will have to decide. The personalized medicine is not going to be based on just the genetic test. Because, as you know, some mutations can be present, but that mutation may not cause a clinical picture. And we have to avoid to make a psychological pressure on the family.
Exactly. Okay, another issue that we had, let's say, several cases, and I'm sure that you had as well, is about unsolicited variations that we find when we're looking into children. For example, if you look at mental retardation, at the same time you can find variations that will cause or increase the risk of cancer in 1 or 2 decades after. But there are some implications for the for the parents, because most of the mutations are autosomal dominant, and if you find something in the children, there may be no implication for the children, but for the parents there are some implications. So, in your experience, what you do in such cases, because I think the situation is a little bit complicated. The parents come with a child with mental retardation, and in addition to finding the cause of mental retardation, we tell them that they are in risk of cancer in future.
Yes, we lived this problem several times in our routine clinical practice. Before the clinical testing, we are giving a genetic consultation and giving a counseling to the family, and we are asking the family to know these details after this test, or are they just requesting the result of testing for mental retardation? But I'm always offering family that we have to inform you about some genetic syndromes like cancer syndromes, because we can protect you from any type of clinical cancer, or we can offer you some solutions. But some families do not want to hear about it. But some families wants to know. Nearly 2 or 3 weeks ago, I started a genetic test for epilepsy, and we found the genetic etiology of the epilepsy, Lafora disorder, and we also found a very clear BRCA2 gene mutation in the child. And we informed about the family, but that family is a very clever family, and they are very ready to work with us and such a clinical follow-up. And we organized a very long genetic counseling session with them. And we informed all. And we made a screening study, and we detect the same mutation at father. And we made another screening study in the family of the father. We are about to complete that, but most probably we will detect several other patients, persons in the family. I think during the pre-test counseling, if the family will approve it, yeah, we have to report it. But if the family do not want to know it, I thought that they have a right not to know. But we discussed about other things. Most probably, maybe father or mother may not know, and it may not want to know. But if they have another children, how we can decide about that children's right? And the brother or sisters of the parents' rights. It's a so complicated ethical question. We made a group discussion in Turkey about these ethical issues, and nearly all the audience say different things about this issue. It's so complicated and very hard to decide for the clinician.
I think we had nearly the same experience, and in my experience, it depends upon the ethnicity of the patients and let's say and education, because in some ethnicities, cancer is considered as a taboo, and they would not like to have the information about the higher risk of cancer, and sometimes it has been very difficult to manage this information. Even if you tell them that we can have other information about other diseases, sometimes they cannot handle it, and that was my experience. And most of the time it was successful, but I have 1 or 2 experience that it was very difficult and needed very, very long genetic counseling to cope with these information. Coming back to the question, you raised the issue of what can we do for the parents for the next child or the next pregnancy. So actually we are performing PGD or PGTM for preventing cancer risk variations in families, and we had a good let's say experience with the family. What do you think about the PGD for the cancer patients?
We are offering PGD studies in these families. There are several ethical articles on the ethic issues on PGD. Some of the authors do not offer such testing, but some others are offering PGD in these families. But I'm always using PGD in such disorders. Yes, we are also using for the severe autosomal recessive lethal disorders, but in cancer patients, it is a very good tool, I think. And because we cannot offer prenatal diagnosis, and we cannot terminate a pregnancy due to such a very late onset disorder. And being a cancer is not the end of the life, and that's why we have to offer PGD, I think. But it depends on the family and the doctor itself. But it's a good option. It seems like a good option, and we can reduce the risk very well, nearly 2 in 1,000. And if it is a autosomal dominant, and in most of the cases we are detecting the autosomal dominant types of family cancers, it's a good option.
Okay. And what is exactly the time limit of therapeutic abortion in Turkey? Just for my information.
There is no limitation for therapeutic abortion, but in the legislation, but we are making the therapeutic abortion mostly till 20th week of the pregnancy. Before the 10th week of pregnancy, family do not need to detect any genetic disorder or any other problem. They can terminate their pregnancy just by signing a paper. But after the 10th week, after the 10th week, a genetic a health commission must decide about it and sign a report for determination. It is free for till the delivery, but we are not making an application like that.
Okay. Very good.
And what about the current situation in Iran? I really don't know about your legislations.
So there is a list of, let's say, the ministry and the organizations responsible for legislation. They have provided some list of disorders that are legally acceptable for therapeutic abortion. So, for example, cancer is not included, as most of the countries, I think, in the world. About timing, it's about 19 weeks, a little bit less or more, but it's about 19 weeks. And so we need to be very vigilant about the diagnosis. We need to do either CVS or amniocentesis. But some ethnicities are looking for PGD because in the belief they do not like to do abortion, TND, for genetic disorders. And hopefully, we have PGD because it not only solves the therapeutic abortion problem in some ethnicities, but in some cases with let's say, cancer disorders with high risk of difficulty in a later age, they can solve the problem.
Yeah.
But it remains many things to do because it is not always the problem of single mutation or a autosomal recessive disorder. We have always polygenic disorders and other disorders that we do not have any solution for the moment.
Yeah. It's a complicated thing. We discussed about therapeutic abortions for years in Turkey, and we tried to develop a better legislation with the Ministry of Health, but we could not. Because when you make a group discussion with more than 5 persons, you cannot produce a good solution.
It is always the same in every country, I think.
Yeah. Because there are some difficult questions about this disorder, this group of disorders. Which one is life-threatening? Which one is not? There are several different literatures, and on the other hand, some mutations seems like a very disease-causing, but sometimes we are producing a wrong decision about that mutation, and biology is a complicated thing.
Exactly, and I think it will progress in a kind of exponential manner in next 2 or 3 years. Everything in genetics. Hopefully.
Yeah.
Okay, Dr. Serdar, that was very good to have you in this live, and I think there are many issues that we can discuss, and we're going to have a joint meeting and joint webinar, as I remember in that discussion. So I hope to have you another time in a kind of series of genetic challenge in our country and your country. And it was very nice to have you in our live in Sava Genome.
Yeah, thank you very much for this meeting. It's a good introduction for us, and most probably we will do several things together, I hope, and we can organize some other scientific activities, as you said.
Exactly, that we will announce in near future.
Okay, thank you.
That was very good. Thank you.
Hey, good night to everybody.
Thank you. Bye-bye.